I used anesthesia exclusively for the first 20 cases with a general anesthetic, and that was mostly for my comfort level and having to not worry about sedating the patient and performing the procedure at the same time. Now the majority of these we don't involve anesthesia with. I'm doing the sedation. I do have deep sedation privileges at our institution, which helps immensely.
We still do about 75%, 80% with moderate sedation. And just maybe here and there, someone under general anesthesia.
I don't think general anesthesia is a necessity. I think it is something it's a luxury that I have and I like to utilize, and I happen to have a very good anesthesia team. So I think, in that circumstance, it's reasonable to use it. For 20% of our cases, we've used moderate sedation, and in hospitals where we have deep sedation privileges, we were able to test the device without problems. I think you have to make sure you have good patient selection and decide that certain patients are adequate for moderate sedation. You have to provide really adequate local anesthesia and moderate sedation as well. We tend to use deep sedation for the times in the procedure where there may be additional pain or more pain than normal. And then, of course, during DFT testing, but it's very possible to do the procedure with moderate sedation alone.
Our very first subcutaneous ICD implantations were performed under general anesthesia. There was a concern in the physician's mind, both anesthesia and implanter, that the degree of pain related to the device implantation was higher than a standard ICD, and that therefore stronger anesthetic would be required. I would say that has changed, that thought process has changed over time, because the vast majority of device implantations are not significantly more challenging or difficult than a standard ICD implant, and that we have found certain times at the implant, during the implant, where more anesthesia could be beneficial for patient comfort, such as making that axillary pocket, or of course during defibrillation testing. By communicating with the anesthesiologist these concerns, the need for total general anesthesia has seemed superfluous, and a moderate or MAC anesthesia appropriate, with that understanding that at times we would need to be deeper than others. I have, in the course of the last 5 years, had an opportunity to see many different physicians implant subcutaneous ICDs, and to discuss with many implanters their individual practices. And I think that the need for general anesthesia is the rare patient. I think that if there is the opportunity to have anesthesia services via MAC anesthesia, propofol, that is sufficient for the vast majority of patients, and it is the rare patient that requires general anesthesia. In that small minority of patients that require general anesthesia, the most common reasons that is the preferred method of anesthesia delivery usually involves airway issues, such as those patients with severe sleep apnea or who have high oxygen requirements, those patients who have high opioid tolerance, like those patients with chronic pain, in whom achieving a deep level of sedation without general anesthesia is difficult.
So the question always arises, is general anesthesia mandatory for S-ICD implantation? We looked at our data at Ohio State. There are very few reports in the literature. We have 2 or 3 of those reports. We saw that general anesthesia in these high-risk patients who had low ejection fractions, idiopathic cardiomyopathy, and dilated cardiomyopathy, along with being on multiple myocardial depressant, drugs, and our anesthetics also depress the myocardium and cause peripheral vasodilation. During implantation of S-ICD with general anesthesia, we had a significant number of patients, probably close to 50%, getting significantly hypotensive. So based on our experience with that, we performed a subset of patients with monitored anesthesia care. Those patients were appropriately selected, so they were not at risk for airway compromise. But they were equally on the sicker side. They actually had lower ejection fractions. However, there were minimal incidents of major hypotension. There's less suppression of the sympathetic nervous system, which basically supports your myocardial activity and also supports the peripheral vasoconstriction, so you don't end up with significant hypotension, which can be detrimental, especially in patients who have lower and severe left ventricular systolic function.
General anesthesia poses its own series of difficulties that could make same-day discharge more difficult. General anesthesia has a more depressive effect on cardiac function, and for patients who have weak heart muscles, sometimes means the administration of medications to augment blood pressure or cardiac output. The recovery from general anesthesia is often longer, and the concern that patients are not appropriate for discharge because they are still under the lingering effects of general anesthesia could make one consider keeping someone overnight, whereas moderate or MAC anesthesia often wears off much more quickly, has very few hemodynamic effects, and leaves patients in a position where they can participate in that decision-making process in the post-operative setting about whether they feel comfortable going home.